Consortium, which is funded by the National Health, Lung and Blood Institute of the US. And we know that sickle cell is made up, the Sickle Cell Consortium is made up of Sickle Cell Data Coordinating Center, the SADC, Sickle Pan-African Research Consortia, that is SPARCO, and the SPARCO Clinical Coordinating Center. We have several key deliverables. The first one is developing a registry, which is now over 30,000 sickle cell disease patients. We also facilitate that African countries can establish standards of care guidelines. We conduct support research based on the registry, and the current priority studies are implementation research, where we have newborn screening, penicillin and hydroxyurea provision. We do have a cohort studies, which is on pharmacogenomics, malaria chemoprophylaxis, and then we also have working groups that coordinate activities across the consortia. We also have several working groups, including the Standards of Care Working Group, which supports the consortia activities. This group is currently hosting this webinar. We do have this series, and I think the next one is going to be in April, and the third one is going to be in March 2023. We have a few housekeeping issues that I would like to share with you. Only the current presenter will have the microphone and camera on, so thank you. I do not see anyone with the camera on, and you also have to make your microphone switched off. You also have to know that you are able to switch it on and off, but we would wish you to have it off unless when you have a question, and then you'll be allowed to speak, or unless you can use the chat box. You can type any questions in the chat box, and the quick Q&A box, the organizer will select which questions to broadcast and which ones we can actually go on after the presentation. There will be a general Q&A session at the end of the workshop, and we expect you to raise your hands and ask questions in the chat box again. We also like to inform you that this session is being recorded, and you're welcome to tweak speakers using the hash #SickleCellAfrica, except if there are any speakers who will be presenting unpublished work, and we hope that's not the case. Again, we have series each month. The host working group for this for the month of March, April, and May will be the skills working group. And then we have the standard of care working group, which will take over June, July, and August. And then the database working group will take over September, October, and November. Thank you. That is as far as the housekeeping starts, but I would like now to welcome our speaker. Oh, I should end, yeah. I would like to welcome our speaker. I need to introduce Stephanie. I have a brief bio for Dr. Stephanie Ibemere. I hope I've produced it right, Stephanie. She's an assistant professor at the Duke School of Nursing. She's been developing a research program that has focused on building healthcare capacity for sickle cell disease providers and sickle cell providers and patients, also to improve access and quality of care. Her research program is both internationally and domestically focused, and we very much appreciate that. Her work in the US centers around the patient experience of our patients' sickle cell disease and how they can access high quality care, which could be expanded through the upscaling and task shifting to advanced practice providers. She's also focused on improving clinical model of care for sickle cell disease in low research settings, both in sub-Saharan Africa through tool adaptation, implementation science, leveraging technology, and community engaged research. She's passionate about addressing healthcare disparities in partnership with communities and co-create feasible and sustainable healthcare interventions for and with patients, providers, and the health system. Welcome, Stephanie. We're looking forward to hear your talk. Karibu sana.
Thank you very much. Good morning from my side. Thank you very much, Dr. Khadija. I appreciate that very nice introduction. I will go ahead and share my slides, if that is okay.
Yes.
Okay, thank you. Please, are you seeing the full slide?
Yep.
Okay, so again, I say good morning to all. Thank you very much for having me. As has been mentioned, my name is Dr. Stephanie Ibemere. I am assistant professor here in the School of Nursing at Duke University. And I would like to begin by sharing some acknowledgements before going on to the objectives of the presentation today. If at any point you have any question, I am an interactive educator. And so you will see by the end of this presentation, we have some questions that I would like for us to all gather here and discuss. And so if you have a response, feel free to put that on the chat. And there will be a point where I would like for us to actually discuss a bit about your experiences at the end of the presentation. But throughout, if you have any question, as has been said, please feel free to ask, and I will try to answer as they are coming. Okay. So to start with the acknowledgements, I would like to acknowledge those who assisted with slides or content that is being used in this presentation. So first of all, I would like to thank the International Association of Sickle Cell Nurses and Professional Associates, for which I am on the board now as one of the chair actually of the marketing department. So that is one organization I would like to acknowledge. And then the second organization I would like to acknowledge is St. Jude's Research Hospital here in Tennessee, who also is part of making this presentation possible and in giving content and advice and information. So moving forward, today I want to help us kind of combine what we know about sickle cell disease and what we know about genetics and apply those concepts to this idea of genetic counseling for sickle cell disease by understanding the importance of genetic counseling and also the role that the healthcare provider has, whether that is a nurse or a community health officer or other persons who might return genetic information. And what their role is actually in returning that genetic information to patients and families. In this presentation, I'll also emphasize the opportunity that we each have to educate families about the importance of getting screened for sickle cell disease, especially when we're talking about trying to apply the concepts of pathophysiology, epidemiology, and genetics to the genetic counseling that we do in sickle cell disease. So let's jump right in, okay? So to start, genetic counseling, or genetic counselors, I should say, are allied healthcare professionals that usually have specialized education in medical genetics and counseling. However, our hope in giving this presentation is to provide you with some of the basic skills or basic information that you will need to be able to return genetic information back to families as you are receiving it following the same principles genetic counselors use in their daily work. So genetic counseling is a process of helping people understand and adapt to the medical, psychosocial, and familial implications of genetic contributions to disease. And in genetic counseling, it requires knowledge of human genetics, a respect for the sensitivities, attitudes, and reactions of patients and families when they receive genetic information. But genetic counseling also requires that we, as the healthcare providers, teach and provide genetic information to patients and families to the full extent of our knowledge and make referrals to additional care when necessary. So that really means that as someone who will return genetic information to individuals, you as the healthcare provider have to familiarize yourself with the science of genetics and then be able to get or be able to communicate these very complex ideas to patients in a way that they will understand. And so essentially what we're trying to do is encourage you to take the time really to understand the underlying genetics of a condition like sickle cell disease, to take the time to understand the underlying pathophysiology of a condition like sickle cell disease, and then also take the time to understand the epidemiology that is associated with sickle cell disease, especially as it pertains to the continent of Africa. If you take the time to do that and to bolster your knowledge regarding sickle cell disease, how it manifests, what are the genetic inheritance patterns associated with sickle cell disease, you as a healthcare provider will be an even better genetic counselor to your patients. Many times people go to genetic counselors already knowing their diagnosis. And sometimes patients and families will come to you as a healthcare provider so that they can receive a diagnosis. So genetic counselors are working with patients and families at different stages in their lives. Some people, like here in the United States, we are able to offer prenatal and preconception counseling. Some genetic counselors work in the pediatrics, others work in cancer, or some work in cardiology or neurology. And then there are still others who actually work in the realm of infertility and assistive reproductive technology. So these are like IVF and things like that. And then there are some like yourselves who work in the community, in the field, trying to expand access to basic genetic screening tests, and then also the counseling that should follow the results of a genetic screening test. So just to give you an overview, genetic counselors provide interpretation of family and medical histories to assess the chances of a disease occurrence or a recurrence. Then also genetic counselors provide education, as I mentioned, about genetic inheritance, the types of testing that might be needed for certain genetic diseases, management, prevention, resources, and research related to the condition that is being tested for. And then lastly, of course, genetic counseling, genetic counselors provide counseling. And I want to highlight, as I do have some questions at the end of this presentation. And so please note, I might emphasize some certain things so that you can be sure to remember them for the end of this presentation. But the third thing that genetic counselors do is provide counseling. And this particular type of counseling is not mental health counseling, but instead psychosocial counseling that promotes informed choices and adaptation to the risk or condition. But at the end of the day, a genetic counselor must be sensitive to the fact that genetic conditions might not only affect that one person who received the test, but it actually often affects the entire family. So genetic counseling has its own approach, and genetic counseling approach can be described as a person-centered approach to counseling for the return of genetic information. Genetic counselors aim to empower the patient. They value the patient's belief systems, and they do their very best to understand the experience that that patient and their family are having as a result of this genetic condition. Genetic counselors do not take what we call a directive approach. And that is really to say that genetic counselors usually present patients with and their families with the available information and resources for additional testing and referrals, and try to act as like moderator of a discussion between patients and families about what they should do next as a result of this new information you just gave to them and the new information they just learned about their family member, and how that information will impact their whole family, as I mentioned previously. So this for you all means that you become not only healthcare provider, but moderator or facilitator of discussions between parents and their children about their sickle cell status, or maybe it's discussions between two parents about the status of their child's or their sickle cell status of their child. And so you are able to present options regarding sickle cell screening in your area. So this is where, again, your own research will benefit you greatly about what resources are available to you. And then as a genetic counselor, or acting in the role of a genetic counselor, you can help move parents, children, family members through the emotions that are often associated with receiving a genetic diagnosis of sickle cell disease or sickle cell trait. Genetic counselors are meant to be non-judgmental. They're not to pass judgment about these genetic information they're returning. They are supposed to accept the patient. They're supposed to accept the decisions that the patient and their family members make as a result of the information that they have received. Genetic counselors are also supposed to be respectful of a patient and respectful of their autonomy, and allow and encourage the patient as well as their family to make the decisions that are right for them. And sometimes it is difficult, especially when we're talking about having knowledge ourselves as healthcare providers of the ramifications of, for instance, when you do genetic counseling, maybe for two people who wish to get married, and you know that they both have sickle cell trait and the chance of them having a child with sickle cell disease is 25%. But our job in the role of a genetic counselor is not to pass judgment about what they should do or not do. We are supposed to help facilitate a discussion about what they would like to do. It's difficult. It is quite difficult, but that is the genetic counseling approach. Generally speaking, though, that a genetic counselor is supposed to maintain an unconditional positive regard with their clients, with their patients, and try their very best to show empathy to patients and families, because as many of you probably know, and many of you can imagine, this appointment between a genetic counselor and a patient and family is very difficult. You can never really tell what kind of emotion you will get as a result of this kind of an appointment. And so you as a genetic counselor have to assume goodwill and maintain an unconditional positive attitude. I will also say that the genetic counseling approach requires you to use a holistic view of the patient and family, so that we can actually understand what exactly is influencing their ability to understand the genetic information that we have given them, and maybe how they might react. You know, if you're good at assessing people's personalities, this will come in handy. It also helps us to use a holistic viewpoint so that we can understand the level at which patients and their family members can actually participate in follow-up care, such as additional screening for themselves or maybe their family members, or even getting linked up to chronic disease care in their local area. So it means that the job of a genetic counselor is to complete an appropriate assessment of the patient's situation and develop a plan that is based on that assessment and the diagnosis of either sickle cell disease or sickle cell trait that you're going to share with them, and then help them, work with them, facilitate with them an implementation plan for following up with screening, if they choose to continue on to that step, if it's necessary, or giving them or offering them materials that explain the risks of disease, and what the complications look like, and what sickle cell disease really is and what sickle cell trait really is, if they do not wish to be screened any further. This will all depend, of course, on the type of testing that is available in the area. And so I try to be as inclusive as possible, because in some of my work, I know that what is available is only an ML test. And so that just shows us sickling, but additional testing would be required. So the key to the genetic counseling approach is really to do all which I am describing, all what you see in the tiles here, without a judgmental tone. What you want is to be a trusted resource, right, of these families and the patients that you have been returning information to, so that if they have questions later on, they know they have someone that they can go to, who will be a listening ear, a positive influence, and maybe not influence, but a positive person to speak with, right? If they come back and need additional help or need help finding information or resources to get additional screening, to get the healthcare that they need, if they, if they find that their sickle cell disease is not being well controlled, you want to be that person for them. So if we move forward, I want to go a little bit deeper into what really is supposed to happen then. If we now understand the genetic counseling approach, what are we really supposed to be doing if we, as a healthcare provider, are initiating a genetic counseling appointment? And I want to preface this by saying, in the next slide, there's actually a video I would like to share with you all. And I just realized I might have to stop sharing and reshare to do that. I hope that's okay. But there's a video that's about 12, maybe 13 minutes long that I think really helps to bring these steps that I'm about to describe to you to life in the form of a cartoon. And so if you will allow me, I will do that in the next slide. But just to start, it's important to understand that a genetic counseling consultation really is supposed to be conducted in 6 parts. One thing that you've got to make sure of before even starting the consultation is that you have made this environment that you are in for the appointment as private as possible, and do your best to maintain confidentiality in that space, and also that your environment should be peaceful. Some of this information that you might be returning might be upsetting, and so you don't want your environment to also be a source of stress in an already potentially stressful situation. Now, that is from the perspective of genetic counseling guidelines in the United States. And so, again, that assessment that you do of the family in your pre-consultation will be important. Does a peaceful environment mean that other family members are present to offer moral support? That might be the case, where here in the States, that is quite limited in who can enter a room at any time. So let's go to step 1. Step 1 is information gathering. So in this step, your job is really to ask questions about the family and medical history, so that you can develop a pedigree for that family. And a pedigree is essentially the history of the family and their disease conditions. So in this case, you would want to ask questions about whether or not any person in the family, going by person, had sickle cell trait. So for example, you're speaking to a mother who just received genetic results about their child, you might ask that mother, do you know if your mother or father had sickle cell trait? Do you know if your mother or father, excuse me, I'm sorry. Do you know if your mother or father had sickle cell disease? The other thing that we have to also remember is not everybody knows if they had sickle cell disease or sickle cell trait. But as I have learned in Western Africa, sometimes there are words that are used in the local language that have been tied to now sickle cell disease or sickle cell trait. So in Sierra Leone, it was bone hurt. My grandmother had bone hurt, and she experienced yellow eyes, and she always had a distended or a large belly, or things like that might be context clues that you can use to gather information about the family and medical history so that you can develop this family pedigree. You have to ask a lot of questions, and you must perform active listening in this particular stage to make sure you're gathering all the information that is available and as much as possible so that you can use that to advise your patients and their families in the very final steps. As I mentioned, you're going to ask medical questions about their medical conditions, and they may not be able to name them, but may be able to give you symptoms. Okay. So again, being open and understanding, again, that's why I started by saying you have to understand the disease complications so that if somebody gives you symptoms, you might be able to tack them to the condition itself or sickle cell trait. So we are going to use this particular step to gather as much information as we can. And if people know the specific condition, that's even better. You can actually use that to draw up a family tree, or excuse me, family pedigree using the family tree. So at this point, you're going to want to ask as many questions again as possible. And then once you get those questions answered, you can actually move to step 2, which is analysis and diagnosis. And so in this particular step, you are going to be focused now on gathering any reports that you have received about maybe a child or maybe their parents that were conducted. I know that in some countries, this step might be organized a bit differently because sometimes what happens is you do step 1 in a pre-consultation, and then the second genetic counseling appointment is actually where you start with step 2. So you might even consider that if you are in the process of structuring your genetic counseling approach, you might consider that step 1 be its own appointment. And at the end of that appointment, you spend some time discussing what will come in appointment number 2. Then when you go to step number 3, we're talking about risk assessment. So this is where you take the opportunity to explain the risk of this disease process or trait process happening again in the family. And so again, I usually use the example of a parent or parents with their child. And so maybe those parents want to have additional children and you have screening results for them. This is where you could use a Punnett square to help them understand what are the chances of having another child, in this case with sickle cell disease or sickle cell trait. The Punnett square I also find is an extremely helpful visual aid for patients and families to understand what I call genetics math, so that they can see this is why these conditions are happening, because when you match up this parent and this parent's genotypes, this is what comes out of that equation. So step 4 is when we are now giving information back. So rather than gathering, we are now giving the information back. And this is where those reports you gathered in the analysis and diagnosis phase are going to be returned to the patient and their family. You are going to use this time to describe those results. You're going to use this time to explain or describe what sickle cell trait and sickle cell disease are. Again, your back work of understanding the disease process and the trait process are going to be important here. And then you will review again the risk assessment of how did this person end up with sickle cell trait or sickle cell disease. And then you'll also talk to them about what it means to have sickle cell trait and what it means to have sickle cell disease. You're going to be very upfront about the disease complications and what is available to them, what resources are available to them for additional screening if they wish for their family members to be screened, and to help them understand the inheritance pattern based on that family pedigree that you have developed for them. Then step 5 is trying to help these families and the patients who have been screened in making a decision that is best for them and their family members. And this piece is where that idea of non-judgmental and positive nature comes in handy. So in this step, we don't make the decisions for the family members. As it stands now with the genetic counseling approach. What we are there to do is to help support them as they have those discussions, as they talk through their emotions about what they have just learned and how they're feeling about this information that they have just received. You can also be present to help them review what you've discussed in the previous steps so that that can help them in their decision making. And then in step 6, our job in the role of genetic counselor is to offer family support and ongoing patient support. And so this is where we might make referrals to the facilities in the area that have additional healthcare options for them. We might, if it's necessary, you might need to screen further if the testing that you have available is not definitive, if it's a sickling test like the ML test. But what, again, is most important throughout all of these steps is that you are providing psychosocial counseling. So being a facilitator of psychosocial discussions that are often very emotional for everyone involved. And then again, your job is to reassess whether or not the family and the patient have any questions that they need answered, and to confirm that they understand the information that has been given to them by asking them to repeat back what they understand about what has been told to them today. Let me, I'm going to stop sharing now so that I can reshare to share sound, okay? So that we can take a listen to this video that I think is extremely helpful in terms of understanding the actual appointment, the actual genetic counseling appointment. So let me see if I can get this to play. And if not, what I will do is I will play it straight from YouTube. So give me just 1 minute. I apologize. Normally it just works, but today it seems it wants to be difficult. I'm skipping the.
Can affect our health. This short video will demonstrate a few key components of a genetic counseling session. Hi Maya,
I hope you all are hearing.
I'm a genetic counselor at Avery Good Hospital.
Yes.
How are you today?
I'm fine, thank you. How are you?
Good, thanks for asking. Before we get started, I wanted to check in and see what your doctor told you about why you were seeing me today, and if you had any questions on your mind already.
Yeah, well, a while ago they told me something about genetic counseling because some people in my family had sickle cell in their DNA, but they said because I'm not sick, I wouldn't have to go in if I didn't want to. But then my dad got kidney cancer and they said it's important I come now, but I'm not sure how those are related, and you can't pass on cancer to your kids, right? I don't know, I'm a little confused.
I completely understand why there would be some confusion. It doesn't seem like those two conditions would be related. Genetics can be complicated, but that's what I'm here to help with. In genetic counseling, we'll know important details about both your personal and your family health histories. Then we'll explain what DNA is and how our genetics can affect our health. This will help us understand if there are any conditions that could be inherited. And if there is a chance for an inherited condition, we will discuss our options for finding out more information about those chances, such as genetic testing.
Okay, that makes sense. So you'll explain how they're related?
Exactly. And if at any time during our conversation, if I say something that doesn't make sense, or you need me to explain more, feel free to ask questions. I want to make sure we're on the same page.
Okay, thank you.
I want to start by taking your family history. I'll ask about the health of your biological family members, meaning family members that were related to by blood and would share DNA with. For example, if you had a step-sibling, you would have different parents than them and not inherit the same DNA. While I'm asking you these questions, I'll be drawing out your family tree. So by the end, we'll be able to see who is affected with the same kinds of health conditions, and then I'll explain how these patterns could be genetic and affect other family members. Then we'll discuss what testing might be available if you wanted to learn more. Conditions we might expect to be genetic are things like physical differences that people have from birth, things that are chronic or long-lasting, or conditions that are severe or unusual. You don't have to tell me about illnesses that are caused by infection or injuries.
Okay.
Starting with yourself, how old are you?
24.
And do you have any major health concerns like the types I just mentioned, chronic, severe, differences from birth?
Nope.
And do you have siblings?
Yes, I have a brother. He's 26.
Is he a full brother or a half brother? Do you share the same mom and dad?
He's my full brother.
And how is his health?
Pretty good.
And do either of you have children?
No.
Are both of your parents still living?
Yes, my dad is 54 and my mom is 52.
And how's their health?
My dad is pretty sick. He was just diagnosed with a kind of kidney cancer. It was called renal something, a long name.
I remember that I read in your referral note, it said renal medullary carcinoma. Does that sound familiar?
Yep, that's what it was. Medullary. I hadn't heard that word before. My mom's pretty healthy though.
Well, I'm really sorry to hear your dad is battling cancer. I'm glad to hear your mom is doing okay. How is your family managing emotionally?
Thanks. It's been really hard on the whole family, but we have each other, so that helps a lot.
Family support is great. Does your dad have brothers and sisters?
Yes.
And are they full siblings or any of them half?
Awful. I have 2 aunts and 1 uncle, and they're all in their 50s, I think.
And how's their health?
One of my aunts had sickle cell disease and kind of died young, and I think the rest of them are doing okay.
Do you know how old your aunt was that died and what specifically caused her death?
I think she was in her late 20s or early 30s after her symptoms got really bad. She was in a lot of pain and had something with her chest, some kind of chest condition.
Acute chest syndrome?
Yeah, that sounds right.
Well, I'm very sorry for your family's loss.
It's okay. My family was actually a bit relieved. I was young then, but my parents said that she was just in so much pain, but it was really hard to get medication from the doctor because they always think people just want drugs. When she died, she at least wasn't in pain anymore.
That's just awful. I'm sorry. Some healthcare providers don't have the same knowledge of sickle cell disease and how it can cause significant pain just because they haven't had to treat people with it or experienced it themselves. Sometimes patients need to advocate for themselves in certain situations, and we do have more resources and support staff who are knowledgeable and can help. Let me know if you or your family would like more information on how to get that support. It could also help to see a provider who specializes and has more experience in your specific condition. You always have the right to a second opinion.
Thank you. I didn't know that was an option.
I remember you saying I won't forget the life checks.
Who talks like that?
You apparently.
Can we watch the replay?
I would love it.
Of course. Does anyone else in your family on your dad's side have sickle cell disease, or do you know if anyone was told they have sickle cell trait?
Well, I don't know if my grandparents got tested, but since she had sickle cell disease, I think they were told that they were probably carriers. I doubt my dad or his siblings ever got tested because none of them liked the doctor.
I know that doctor's appointments and tests can be really stressful. Could you tell me more about your family's experience with the medical system?
I think just a lot of bad experiences. Like with my aunt, they treated her like a junkie or something. They didn't believe her and thought she was making it up. We already got judged enough in the regular world, and getting that from a doctor felt even worse because we are supposed to trust them, but it felt like they didn't trust us. I think that made my family wary about going back to the doctor.
That's completely understandable to not want to go through that same experience again. I know of some great physicians here in this hospital, so if your family is open to seeing a new medical provider, we can help connect them to someone who could provide them the care that they need.
Thank you for that. I'll talk to them about it because they might be more likely to talk to someone they can trust.
How are both your grandparents on your dad's side doing? Are they both still living?
Yes, and they're pretty healthy besides some of the regular stuff like high blood pressure.
Great. So I just have a few more questions to get your mom's side of the family and their health history. Does she have siblings?
Yes, one sister who's pretty healthy.
And how about your mom's parents? Are they still living?
My grandma is, and I think she's doing fine. My grandpa died a couple years ago, but he was pretty old. I don't think anything major happened.
Okay. And last question, what's your ethnicity? Or if you know, what parts of the world are your ancestors from? We ask because some conditions occur more often in people with certain ethnic backgrounds and from certain parts of the world. Having this information could help us understand your risk.
My family is African American. We don't know more than that and can't trace it back to a country or anything like that.
Sure, I understand. That's still very helpful information. Thank you for answering all of those questions. I know these things aren't always easy to talk about. Next, I want to talk about what genetics is so you have a better understanding of how conditions like sickle cell can be inherited or passed on in a family tree. So tell me, what have you heard about genetics before or seen on TV or the internet?
Yes, I think I learned about it in school, but I don't remember a lot, so I probably need a refresher. But it is something that has come up in my family because of sickle cell, and I've seen ads for those DNA tests to find out where your family's from.
Okay, good. It sounds like you have some familiarity already. We can start a refresher with some pictures I have here to make it easier to follow along. So what is DNA? What does genetics mean? Our bodies are made up of cells. And inside each cell is our DNA. You can think of DNA as a whole set of instructions for our bodies. Pieces of DNA called genes are like individual sets of instructions. These instructions tell our bodies how to grow and how to function, like determining the color of our eyes or how our heart or lungs develop. We have 2 copies of each of our genes because each parent passes on half of their genes when they have children. These genes can be passed on in any combination. It's normal to have some variation in our DNA between generations, and most of this variation won't affect our health. But sometimes changes to our genes can cause health complications. Here's a picture of how changes to genes can be inherited and cause a health condition. Since we have 2 copies of each gene, sometimes when we have a change in only one copy, our health isn't affected because we still have another copy that works and keeps us healthy. But if we have changes to both genes and none are working, we would develop a health condition. We say conditions like this are recessive. Sickle cell disease is a recessive condition because you have to have 2 gene changes in order to be affected. Having just one change would make you a carrier of sickle cell disease. We call this sickle cell trait. People with sickle cell trait typically won't have any symptoms, except in some very rare cases that I'll talk about later in the session. Since we know there's a chance that you might be a carrier, what do you think it would mean to you if you found out you were a carrier?
So if I'm a carrier, I wouldn't have the condition, but if my partner is also a carrier, our child could get both the genes with changes and end up being sick. I think that would make me scared and sad. On the other hand, if my partner is not a carrier, our child won't have the disease but might have the trait like me, and I would be very relieved.
Exactly, and you're right. This can be very scary to consider. When we think about the actual numbers, 2 carriers having a child together would have a 1 out of 4 or 25% chance of having a child with sickle cell disease. Their children would have a 1 out of 2 or 50% chance of being carriers. And then they would have also a 1 out of 4 chance of inheriting both unchanged genes.
Okay, I understand. This is good information for me to know.
Based on the information you gave me, there is a chance your dad is a carrier of sickle cell trait, which means you also may be a carrier. Could you tell me what you've been told about what happens when you have sickle cell trait or sickle cell disease?
I know it's a blood condition that can cause pain and other symptoms, but I wasn't told any more details.
Good, you have some of the basics. Allow me to explain more. Sickle cell disease is a condition that affects the shape of the blood cells so that they can't carry oxygen very well, and it can lead to things like anemia and other health complications.
I've been super open about my struggles with mental health, and I really believe there shouldn't be a stigma around the subject or...
About 1 in 13 African Americans are carriers of sickle cell trait, so it's fairly common. The sickle-shaped cells actually can protect against malaria, a disease people can get from a mosquito bite. Malaria is more common in parts of Africa. That's why people with African ancestry have sickle cell trait more often than other ethnicities. Earlier, I mentioned that some carriers of sickle cell trait might experience some health complications. I'll explain more about that now so you can start to think about if finding out whether or not you're a carrier is something that you would want and think would be helpful.
Okay.
It is extremely rare, but an associated risk is an increased chance of the specific cancer your dad had, renal medullary carcinoma. Also, situations that involve high exertion, extreme temperature, high altitude, or dehydration can lead to fainting, pain crises, muscle breakdown, and worst case, and very rarely, sudden death. There are also certain drugs that might cause adverse reactions for sickle cell carriers. So with your dad's diagnosis and the family history of sickle cell, there is a possibility he is a carrier, which means you also might be a carrier. How do you feel knowing about some of these risks to your own health? Do you think having more information about your genetic risks would be empowering or cause more anxiety?
I'm a little bit worried about having symptoms and getting sick, especially because my dad has that cancer, so I guess those other things are possible for me. If there are ways I could know to prevent or avoid them from happening, that would make me feel a lot better.
So that leads me to the next topic, which is genetic testing. If you are interested, we can offer you a test that will tell us if you are a carrier or not. Part of the reason some people decide to have this type of testing is to take steps to protect and manage their health, just like you mentioned. Another reason some people may consider testing or not is how this information might affect their other family members, including planning for future family members, aka having children. For some people, thinking about how this information might affect their family members could cause more stress and anxiety, but for others, the possibility that their family members could get information that helps them, it could be reassuring. Have you thought much about how this information might affect your relatives or family planning?
I guess since we started talking about how genes are passed down and how we become carriers, I realized my brother could have the same risks as my dad. That does worry me. I don't think he totally understands this, so I think me going through it might make him more comfortable with going through it himself. And I'm not sure if I'll even have my own kids or maybe adopt, but I do think when the time comes, I want to do what I can to make sure they're healthy and have as much information as they can.
It sounds like you feel that having this information would be empowering for you. Are you thinking you would want to move forward with testing?
Yes, I do. I think it will help my peace of mind and help with talking to my family.
Great. I'll start putting in the orders to get testing coordinated for you.
I want to stop it there and go back to the presentation. Obviously, this is best case scenario that we have just watched. But I think and I hope that it does help you all feel like you can understand how the steps apply in real life. I also need to pause and give credit where credit is due. This animation was developed by a genetic counselor colleague of mine called Leanne Jimmins, who has just, it's been a couple of years now, has become a genetic counselor, and as part of her training was asked to develop this video. And so I would also encourage you all, as you're moving further and further in your ability to do genetic counseling to the extent of which you wish, it would be great to see this type of video produced from the African context, from the differences in culture and how the differences in care might impact how a video like this is done. And so I look forward to the day that that happens. But I do hope that was helpful, and I've put the link to the video in the chat. So on that note, one thing that you know was alluded to in a way in that video is this idea about grief and what grief might look like in the midst of a genetic counseling appointment. And so I just wanted to highlight here that you can be prepared and not be caught off guard by anything or any of these emotions that might happen, because they're expected. The other part that I would like to highlight about grief is, though I have them lined up in linear form as though they happen one after the other, that really is not how it happens. You might find that people are having all of these emotions at the same time. Some people might jump around. Some people might stay in one area rather than move through these different phases. And so again, that ability to do a proper assessment will come in handy here. So you'll be wanting to look for signs of disbelief, quick changes in their mood, crying, screaming, complete silence, right? Wishing for a different result. And sometimes some people might just say to you, I'm okay. I'm just fine. The key though is you don't want to join them at whichever emotion they are. Our job is to remain level-headed despite what might be happening emotionally for them, because one thing is, if you join them, they will also ramp up too. So an example I like to use is if you have a parent that has just received genetic information and they have now started screaming in the office, please don't join them in the screaming. This is not exactly what I mean when I say empathy, but I think what is the most helpful is to maintain a calm tone and to offer that parent a space or a chance to let out those emotions. I'm not saying that we should try to get them to not have those emotions. You might find a space where they can have those emotions more freely, or the case may be that there's a person in the family that can help them through those emotions. And so you might ask if you need to call that person and bring them in as an additional moral support for them. That can really, really be helpful when emotions are running high. The other thing you can do is offer them water, offer them a fan. Just anything you can do to help them process the emotion is what needs to happen in that kind of a situation. You want to offer your listening ear in all cases, in all emotions, and then also perform active listening as they are offloading or downloading, if you will, their emotions into the space that you're in, so that you can either find ways to address those emotions or offer a resource to them that you might know about in the area that could help them through what they're dealing with. Sometimes people just need to have someone there that is listening so that you can respond to their questions, and at times that is just enough. So I'm going to go to a topic that is it's a difficult topic, and it's called misattributed parentage. And so this is something that occurs when an incidental finding comes from a genetic test where it is where it is found that the person that has been assumed to be the mother or father is probably not the biological mother or father. Again, as you will recall, the road to sickle cell disease or sickle cell trait is very specific, as this is an autosomal recessive condition. And so sometimes, and by sometimes we mean 1 to 10% of all births that receive genetic testing might have the incidental result of misattributed parentage. And so according to the literature from countries like the US and in the UK, it is more common to find these types of, or to get these kinds of findings for non-paternity. So meaning the father is not the biological father, rather than non-maternity, which is where the mother is not the biological mother. And according to current guidelines or current evidence-based practice, there's not really a consensus about whether or not to disclose those types of results or not in the midst of a genetic counseling appointment. However, what there is consensus about is that there's a need for a pre-consultation visit, which is why I mentioned it might be a good idea to break up the genetic counseling appointments into 2. where you discuss information gathering, but then also share with them what could happen in the consultation visit, and that there's a chance for incidental findings such as misattributed parentage or the result of other genetic conditions if other genetic tests are run. The other place where we have agreement is that the research team or health system needs to have a consistent policy about what they want to do with their consenting process and whether or not in that consenting process you want to disclose misattributed parentage or not. That is a decision that can happen at the health system level. This is something that can be reviewed with the parents in the pre-consultation visit, and it's the role of the genetic counselor, the person in that role, to make sure that parents understand, or whoever might be involved in that visit understand the implications that this type of information has. It is generally preferred that in instances where both parents and the child have had their genetic testing completed, all trait and disease statuses can be disclosed, but discussing maternity and paternity should not really be a part of that discussion. And the reason being, the test was not done to determine paternity or maternity. There are specific tests for that. A genetic test for sickle cell disease is not the final test you would use to determine somebody's paternity or maternity. Thus, the overarching practice is not to disclose incidental findings because of this, because this is not actually a paternity test. There is work that has been done by a few people in the field about how you can make decisions on whether or not you would disclose genetic information, incidental findings like misattributed parentage or not. And I would encourage you all, as you develop your program in your different spots, whether or not you want to disclose this kind of information. And I would strongly encourage the involvement of the community. So with that being said, I've come to the end of the presentation. I do have some questions for you all. I just want to move us straight to the opportunity for everyone to share the types of resources they have available in their area for yourselves and for your patients. And then I'll also now just take questions if there are any. So I thank you all for listening and appreciate the time that you have spent here with me today.
Thank you, Stephanie. Now we welcome questions from the audience. Karibuni. You could raise your hand up, or you could, you could just start asking. Any questions?
Good afternoon. Thank you, Stephanie, for a very succinct presentation, quite eye-opening. Like you rightly said, in different locales, there are different reactions to in genetic information being presented to a patient or a mother or someone who's at risk of having children with sickle cell, because some of them don't know. I just wondered, do you have like a template of these steps that one could use to develop a program? We're in the process of developing a program in Lassus. And because Lassus is a teaching hospital and has been charged with kind of creating frameworks for these things in the state, it would be nice to develop a proper program where people are trained on a regular basis. We have resident doctors. We have, of course, we know that counseling can even be done by non-medical personnel, volunteers even. So it interests me to build a more robust counseling unit that can actually train others. So it would be nice to have a framework that will help us remember to include everything. Yes, of course, there will be peculiarities in Nigeria, culture, traditions, the terrain itself, and this even differs from state to state. Do you have any material of that sort that we can fall back on and use as a benchmark to develop a program and our own documents? I ask this knowing that you're probably your documentation is probably on an electronic scale. We haven't got there yet, but we're hoping to get there.
Yes, Dr. Nkiwumi, thank you very much. If you're at Lesotho, I was just at Sickle Cell Foundation. It should be across the street if I'm thinking of the right place. And
not quite.
Not
That's
quite.
Is
the wrong one.
The
other one.
The one
okay.
Loose.
Okay. So I what I can do for sure is I have shared these slides with our organizers. I don't know if there's intention to send them out, but I am fine with them being sent out. And you can use the slide that has the steps there. And what I can also do is there are some materials from St. Jude's Research Hospital that I already adapted for Nigeria, I believe. So let me, if you don't mind sharing your contact, I can get that to you, or maybe I can send it to our organizers. That way they can share it among the whole team. And those resources are genetic counseling manual, handouts for incidence and prevalence of sickle cell trait, sickle cell disease, those kinds of things. So I think those might be useful in terms of developing the program that you are talking about. I hope that will be helpful. But I know that at the Sickle Cell Foundation, across from Luth, they have genetic counselors there that I think might also be very, very helpful to you.
I was actually trained there for as a genetic counselor. But being trained for yourself is not the same thing as setting up a training program for counselors.
It's true. So I can share those resources. I would share that. I see your email now. I would share them and get that to you, okay?
All right. Thank you so very much.
Yeah. Thank you for coming. My countrywoman.
Thank you very much. We welcome other questions from anywhere else.
I see. What is the percentage of a parent giving birth to sickle cell disease children if both are carriers? So it's 25%.
Yeah.
It's 25%. Every time, with every childbirth, 25%.
Right. I suppose we could ask you to send those materials to the organizers so that they can share to the larger audience. Yes.
I would do that.
Thank you very much. Do we have any other questions, concerns? None? I was thinking maybe the first thing we could do is translate the cartoon. If we could get someone to work on it and we have that in our local language, that would be a start apart from everything else. Otherwise, I will have to say thank you very much, Stephanie. That was a very intensive and learning experience, but I think getting it into practice is going to be much more difficult. Oh, Karibu, Josephine. There's a question from Josephine Gaia. You're very welcome.
Hello, thank you very much, moderator. My name is Irene Ninja. I'm a Skills Development Working Group Lead from SPACO. Thank you so much, Stephanie, for accepting this invite. I'm the one who wrote an email to you. So yeah, I'm really happy to have you today. So that's all I wanted to say.
Thank you for having me. It's really a great honor. And I think I saw one of my colleagues from some time ago when I was first starting as a postdoc. Dr. Daima is here.
Yes.
Yeah.
Thank you so much.
Yes, thank you very much for having me. I'm grateful.
Back to you, moderator.
Thank you. So I was really looking forward to have some questions for Stephanie here, but I guess people are still trying to understand what it takes. And I think one of the challenges we're going to face is, you know, when you do genetic counseling, I think it's the screening for paternity. That's going to be an issue. But again, I guess we'll have to look into what the country guidelines say, what is right and what can be done and what cannot be done. So thank you very much, Stephanie. I do hope we're going to hear from you in the next time we need your assistance in this series. So thank you very much,
way
everyone.
I can help.
Yes. Thank you very much, everyone. And thank you again, Stephanie.
Thank you all very much. I appreciate it.
Thank you. Bye-bye.
Bye.
Bye-bye.
Bye-bye.
Thank you all.
Bye. Thank you.
Bye. Thank you.
Bye.
Bye-bye.